I am making a video on demonstrating shoulder dystocia and hopefully how to resolve that. Some of the risk factors for shoulder dystocia is any kind of abnormal pelvic, anatomy in general, gestational diabetes, post-term, previous shoulder dystocia, any suspicion of macrosomia, any prior assisted vaginal birth, forceps or vacuum or anything like that, and labor dystocia can be risk factors, but there can also be absolutely no risk factors whatsoever over 50% of the time with shoulder dystocia. Also something to keep in mind, complications after shoulder dystocia can be postpartum hemorrhage, fistula, 3rd and 4th degree lacerations, uterine rupture, and in the baby, brachial plexus injuries, clavicle injuries, death, hypoxia, and fractures of the humerus. I have a love-hate relationship with mnemonics. I think there are far too many of them for us to even consider remembering a mnemonic in the moment. There's the helper one that is listed in Miles and I think most of the texts. The best training has one called Fudge. I guess that'll be backwards for you guys. Flex. Anyway, I won't bother with that. But so just in general, first thing you're going to do is when you see something that may be a problem, a baby may be, kind of slow to crown. Once they crown, like the head still isn't coming. And once baby's head is out, you may see that turtle sign. It looks like baby's getting sucked back in. We get these big chunky cheeks. And you can just see that baby isn't coming. Something has stopped baby's progress. So the first thing you want to do is check any of the other things. You can just kind of check gently, see, is there a cord? Let's see, I've got my little doll here. As baby, is there a cord? So you're coming in here, you're checking, is there a tight cord? Is there a short cord? Is there anything else to indicate that that anything is going wrong with, soft tissue of any kind? If it doesn't feel like there's anything else going on, you can ask your assistant, whoever you have with you, for some assistance. And most of the mnemonics suggest that you just go straight to the McRoberts position. Legs coming forward on mom, to rotate her body and hopefully make a little bit more room in the back of the pelvis back here. And if that doesn't work, we're going to try the suprapubic pressure. And it's important to have a feel at this point in time where baby's at and which direction you're going to try to get baby to move. So if you're using suprapubic pressure, you're coming in to find the baby's shoulder, and you're trying to not just get the shoulder off of the pubic symphysis, you're trying to get that breakdown of the shoulders to come forward so you can get that rotation that you're looking for, to get that the shoulder, that anterior shoulder off the pubic symphysis. If that doesn't work, also, I like the idea when you're trying to move shoulders of going in with fingers on either side of the shoulder, if possible, so you can kind of see if you can get movement one way or the other. And if you have to have two hands in, for the Woods corkscrew, for example, that you can have two hands. And this, my previous preceptor that was a chiropractor, she told me to always do that because it protects baby's neck, that it provides that support and stability if you can, to be able to go in on either side of the shoulder and try to go either direction. Let's see, what else do I want to talk about? If you're not having any luck with the anterior shoulder, then you can go in and attempt to remove the posterior shoulder as well. I guess before I was really getting stuck on any of the internal movements, I would be wanting to move mom. I like going to the gasket maneuver, just turning mom over altogether. Like we talked, it can be really helpful. Just the getting to a different position can help get whatever, can help get some movement and help baby, just move. So the other thing that I wanted to talk about, mainly because I just wanted to go through it one more time, I guess let's not have a posterior baby, is the posterior arm sling traction. When I was kind of practicing this over the weekend, I was like, I don't think that's anything that I would ever do. And then I think watching some of these videos that we watched in class today and realizing like really how much force these midwives and physicians are having to use to try to get baby out. I think that I have reconsidered that, and I think it may be a good out-of-hospital tool. And it's really simple. You're going to take a cord of some sort. I really like the idea of using the D-Lee because it's usually on our birth tray, and we're going to have a resuscitation tray close anyway. Today I'm using some headphones of my children just for the demonstration. So you're going to go in and you're going to get, I'm actually going into the posterior arm here. You're actually going and slipping this like through baby's armpit and retrieving, let me drop my baby here. With the left hand, and ooh, look at how well that worked. And so it won't be doubled over. You'll just have, one side of the cord sticking out, and then you would have hemostats close, and you would clamp that just to have kind of something else to hold on to. And then you're using that to really just try to get rotation and get some movement and get that posterior arm out. I think in a really serious dystocia situation, I think that this would be a really good option to just get that movement with baby. And that would be one of my kind of last resort things to go to. I think that's everything I wanted to talk about, and if not, I've rambled long enough. Thanks.